First, my disclosures. I own intellectual property related to ThyroSeq Test and receive royalties through my employer, University of Pittsburgh. And my employer, University of Pittsburgh, has a partnership with ExpressMed laboratories to offer ThyroSeq in several regions. So as you all know, patients with thyroid nodules come to see medical attention to differentiate benign and malignant thyroid nodules. In those cases where clinical exam and ultrasound are suspicious, typically fine needle aspiration biopsy is performed, which collects cells for cytological evaluation, which remains a highly informative and cost-effective way to triage thyroid nodules. And indeed, since introduction of fine needle aspiration, the proportion of thyroid surgeries performed for benign nodules has dramatically decreased, but it has not eliminated. And this is because of indeterminate thyroid cytology. As you know, most of the samples evaluated by cytology are diagnosed as benign, and those are managed conservatively without surgery. Approximately 5% are malignant, and those treated as thyroid cancer. But 20 to 25% of thyroid FNAs have indeterminate cytological diagnosis. It means the cytology alone is not able to say if it's a benign or malignant. These patients typically undergo diagnostic surgery, but only small proportion of those are cancers and majority are benigns, and this surgery could be avoided if diagnosis of cancer could be, or benign disease could be established preoperatively. And this sort of sufficiency of diagnostic procedures is the main focus of modern molecular tests. Basically, modern molecular tests, all of them have been created to address this issue and stratify nodules with indeterminate cytology into those that are likely benign and can be treated as benign, and those that are likely malignant. This was the first indication for molecular testing. But more recently, molecular testing can have even more significant impact on these patients, because it could allow not simply predict high probability of cancer, but suggest if it is a low-risk cancer, and this patient can be sufficiently treated with thyroid lobectomy, or this is a high-risk cancer, and those patients would best be treated with upfront total thyroidectomy. So all these molecular tests use the current advance in molecular genetics of all cancer types, including thyroid cancer. Since over the last 20 or so years, we've learned a lot about molecular profiles of thyroid cancer, and also utilize modern technology, which is called next generation sequencing, which allows us to interrogate multiple regions, hundreds, even thousands different regions in DNA using a small amount of material. And this is exactly an ideal technology for fine needle aspiration samples. So this slide provides an overall overview of genetic alterations identified in thyroid cancer. And I want to stress that three main groups of thyroid alterations are known to, of genetic alterations are known to occur in thyroid cancer. They are point mutations, gene fusions, and copy number alterations. And if we look at main type of thyroid cancer, for example, papillary carcinoma, most of these tumors have BRAF V600E mutations. Many also have RAS mutations. BRAF-like gene fusions such as RET or NCRK are most common in this tumor type. Follicular carcinomas mostly have RAS mutations and other mutations that are RAS-like, They behave biologically and actually clinically very similar to RAS-like tumors. One of the examples of RAS-like fusions is, for example, PPR gamma fusion, and also copy number alterations have significant prevalence in follicular carcinomas. Hürter cell carcinomas have a very distinct molecular genetics. Most of these tumors develop through a mechanism of multiple copy number alterations. This is a very important mechanism, a very distinct mechanism for developing Hürter cell carcinomas. Medullary carcinomas typically have red point mutations or RAS point mutations. And even poorly differentiated anaplastic carcinoma, they may have ABL mutations such as BRAF-RAS, but they are characterized by this second hit, late mutations in TERT and TP53 gene that really makes these tumors highly aggressive and result in patient mortality. So if you look at this table, you would see that if we test for all this type of genetic alteration, we can identify almost all thyroid tumors and all type of thyroid tumors, benign and even borderline as NIF-E. So this amount of knowledge, this huge amount of knowledge laid background for generating and advancing molecular tests like ThyroSeq and others that I'm going to talk today. So when we are talking about molecular tests for thyroid nodules with indeterminate cytology, some of them are using both DNA and RNA to detect all mutations, fusions, copy number alterations, and gene expression alterations. An example of such test is ThyroSeq. There is a pretty good RNA-based test which uses gene expression profiles of Ortisaferma, and less common, less validated test that use microRNA is ThyroMe. I'm going to spend most of the time sharing with you information and general clinical impact of ThyroSeq because this is a test that we use at our institution. But again, I want to say that other tests also exist. Virtually all molecular tests, including ThyroSeq, have undergone evolution, which follows the increase in understanding of our knowledge in genetics of thyroid cancer and developing new technologies. This test started many years ago as only 7-gene panel before NGS was introduced. Then with next generation sequencing migrated to 15-gene, 56 genes. And now for the last 4 years, we use this mature version, which is called ThyroSeq version 3 genomic classifier. So what is this test and why it is important for us to understand how such tests work? So this is a next generation sequencing test for DNA and RNA that starts with determining FNA cellular composition. So modern molecular tests can easily detect if nodule is composed of thyroid follicular cells, or this is a parathyroid, for example, nodule, or it's medullary carcinoma, or it's even metastatic lesion. And then it progressed through analysis of 112 genes for ThyroSeq for point mutations, gene fusions, copy number alterations, gene expression alterations, which allow us to interpret the combined results and call test negative or positive, provide detailed mutational findings, but most importantly, provides specific cancer probability, a cancer of recurrence risk, and therefore suggest a potential clinical management for the patients. Also want to mention that in contrast to some other tests, ThyroSeq can be offered in not only in freshly collected samples. This is a modality that is most common in the United States, but for example, using cytology smears. So already existing cytology smears, PAP smears, PAP stained or DIF-Quick can be used for molecular analysis. And this really opens this test to be offered in multiple regions of the world, since it doesn't require storage and expensive shipment to the United States. If we talk about diagnostic utility of molecular testing, Diagnostic utility of ThyroSeq was validated in a large multi-center study that we published in JAMA Oncology, one of the premier medical journals, which involved 10 centers, including one international center in Singapore, and the rest were United States centers, where we in a completely blind manner, we evaluated close to 250 nodules with Bethesda 3 and 4 cytology, and find sensitivity of 94 and negative predictive value of 97%. What it means? It means that the residual cancer risk in ThyroSeq negative test is approximately 3%, very low, similar to cytology, to benign cytology, and therefore these nodules may be observed in most of the patients. When we look at specificity and positive predictive value, it was 82% specificity and 66% positive predictive value. Overall, the benign poll rate was 61%, which means that 61% of patients with cytologically indeterminate thyroid nodules could avoid surgery based on the results of this molecular test. But more importantly, this test doesn't only provide information if this is likely benign, likely malignant nodule, but it can also predict, based on the specific molecular alterations, what kind of cancer is likely to be found on surgery in these nodules. And indeed, in this study, some of the nodules were identified high-risk mutations. This is likely to be widely invasive or metastatic papillofollicular carcinomas. Then there was a group of BRAF-like mutations, which typically found in classic papillary carcinomas. Then there were RAS-like mutations found in follicular pattern lesions, such as encapsulated follicular variant of papillary carcinoma, follicular carcinoma, NIFT-P. Then there was a group of copy number alterations, and those tumors are likely to be Hürther cell carcinomas. And finally, gene expression alteration groups, where we identified some medullary carcinomas, metastatic tumors, and some other tumors. For a quick second, I want to talk about this RAS-like group. As you can see, when test is positive for RAS-like mutations, about 62% of these nodules will be cancers, while about 38% will be benign adenomas. But it's very important to realize that these are tumors. These are benign tumors driven by the clonal mutation. They are not hyperplastic nodules. And the reason why it is important to recognize it is that we have to understand that thyroid cancer, as virtually all other cancer types, don't develop as either benign and forever stay benign, or as a malignant and from the beginning they're malignant. Many tumors, particularly these RAS-like tumors, develop through the multi-step progression from benign adenoma to, for example, acquiring nuclear features and becoming NIFT-P precancer condition which already acquired nuclear features of papillary carcinoma but remain fully encapsulated, to invasive follicular variant of papillary carcinoma or follicular carcinoma. So a number of the nodules which detected by molecular analysis like ThyroSeq as positive and which come as benign or after resection are actually pre-cancer lesions that probably should be removed to prevent their progression to a full-blown cancer. So this is about the diagnostic utility of molecular testing. What about the next application? What about the prognostic utility of molecular testing? Over the last 10 years or so, we learned a lot about correlation between specific molecular profiles and probability of cancer recurrence in thyroid tumors. For example, this is a study from South Korea showing or by analysis of more than 500 differentiated thyroid cancers. The tumors that had RAS-only mutation, they were low risk, very few of them recurred. Tumors that have BRAF mutations, about 5 to 8% of them recur, so they're very similar to ATA intermediate risk group. And tumors that have a multiple mutation, and specifically a combination of early drivers, such as BRAF or RAS, plus late drivers, such as TERT or TP53, were high-risk tumors with a very high probability of tumor recurrence. So this is one of multiple studies provided this background, provided very important information to use molecular testing for risk stratification. And this is a study from our institution published last year in Cancer, showing that with the low-risk ThyroSeq signature, less than 1% of tumors will give distant metastasis in 5 years. With the intermediate risk signature is 5 to 9, and with high risk signature is 20 to 35%. So preoperatively, before even surgery occurs, we can predict what is the chance for these tumors to recur. And therefore, this information can be used to formulate the treatment plan and extent of thyroid surgery. So, to summarize this part of my discussion, we all know about the American Thyroid Association risk for structural disease recurrence classification as a low risk, intermediate risk, and high risk. Almost all questions about management of patients with thyroid cancers are related to this risk stratification. When we decide to complete thyroidectomy, total thyroidectomy or not, to give radioactive iodine or not, how closely to observe the patient with cancer, basically depends if we put this patient into low risk, intermediate risk, or high risk for recurrence group. But this classification typically requires surgery. So you have to remove a lobe with a tumor to evaluate for pathological features and perform this risk stratification. However, now, with molecular risk stratification, which provides very similar probabilities of recurrence, we can provide such risk stratification preoperatively. Again, this is the second application of molecular testing for thyroid nodules with indeterminate cytology. So then one can say, look, we have a very good ultrasound that can predict sort of how likely this tumor is cancer. We have nodule size. We can have other imaging technique. Do we really need molecular testing? Maybe we can manage patients with indeterminate thyroid nodules based on ultrasound characteristic and nodule size. And the question is, not in all cases. Ultrasound and clinical exam is absolutely critical and important part of patient's workup, but additional diagnostic modalities would improve significantly our management of patients with indeterminate thyroid nodules. As an example, this is a 50-year-old female with very small 0.9 cm thyroid nodule, which present to endocrine surgery clinic with enlargement from 6 to 9 millimeters in a short period of time. Also, nodule has been there for a long time, and ultrasound was performed. As you can see, I mean, this seems like an encapsulated nodule, but not really an overtly worrisome ultrasound. But cytology was performed and reported as follicular neoplasm or lesion, Bethesda 4. Because of indeterminate cytology, molecular testing was performed, and this is the ThyroSeq report in this test, which showed positive test result with very high probability of cancer, a recommendation for surgical excision. Interpretation part of the report provided more detailed information. Indeed, we identify mutation in RAS. This is an early event. TERT and PIK3CA genes. These are late alterations associated with highly unfavorable prognosis for the patient. And then the interpretation further stated that this molecular profile confers a very high probability of cancer and increased likelihood of cancer with high risk for recurrence and with tumor dedifferentiation. Because of the molecular signature of aggressive cancer, total thyroidectomy can be recommended. And then the report contained all detailed information about the mutations found. So in this case, despite the molecular report predicting very high risk cancer, the nodule was so small that surgeon decided still to go with lobectomy. Lobectomy was performed. On lobectomy, there was a 1 cm follicular thyroid carcinoma, minimally invasive, but already with progression to poorly differentiated thyroid carcinoma. Obviously, that patient had to undergo completion of thyroidectomy and radioactive iodide treatment, but this case demonstrates and highlights why it is really important for us to understand better and better stratify nodules with indeterminate cytology. Speaking about two main tests that are used in the United States, ThyroSeq and Afirma, how their performance is compared. I just mentioned this independent validation test comparison study that was performed at UCLA. Study involved 370 patients with Bethesda 3 nodules that were sent 1 month to Afirma, 1 month to ThyroSeq, then again Afirma, and then ThyroSeq. So this is the only study that basically side by side compared the performance of this molecular test. What they found? They found that diagnostic performance of both tests was high and not statistically different. However, lower proportion of samples were inadequate for ThyroSeq testing. It's 4% versus 9%. It was a higher benign call rate for ThyroSeq, 60% versus 53%. The benign call rate determined how many patients were called benign and can avoid diagnostic surgery. And then importantly, the author mentions that reported ThyroSeq had enhanced use to diagnose and prognosticate thyroid cancer based on specific molecular alterations detected. So they concluded that in light of these findings, the choice of molecular test may hinge on factors other than diagnostic performance, such as cost, processing time, sample inadequacy rate, and information regarding specific mutations that may guide future patient management. So in summary, if you perform comprehensive molecular tests with both diagnostic and prognostic components, how will this help you to individualize the management of patients with indeterminate thyroid nodules? Imagine that you have, let's say, 100 patients with Bethesda 3 and 4 cytology, and you perform molecular testing on these patients. First, about 1% of these patients, of the samples, will be of non-thyroid follicular cells. It will be either medullary carcinoma or parathyroid, or even metastatic non-thyroid follicular cell lesions. 99% of them will be thyroid follicular cell derived nodules, but molecular testing results will come in different flavors. Approximately 60% of nodules, the test result will come back as negative. And these nodules not only benign, but they most likely are not even not neoplastic, they are hyperplastic nodules. These nodules have extremely low chance to recur or hurt the patient, and for that reason can be observed safely. Approximately 3 to 4% of nodules will be reported as currently negative. They are positive for low risk or low level alterations. These are early tumors, most of them are benign. They just need to be followed closer, because some of them eventually, not now, but in few years, may transform to cancer. So we recommend active surveillance for these patients. So repeat ultrasound in a year, see if nodule is growing or not, and then to decide what to do with the patient. And test positive result will come in 4 different flavors, not just positive. It will be positive for RAS-like mutations. And this is likely to be low-risk cancer or NIFT-P. You remember that tumors that grow and through multiple steps progress from benign to malignant. These patients can be safely treated with lobectomy, not as a diagnostic, but as a therapeutic lobectomy. Test results can come positive for Hürtel cell type copy number alterations. Many of these cancers are intermediate risk, and lobectomy or total thyroidectomy choice will depend on the nodule size, location, and other ultrasonographic features. Test results can come as positive for BRAF-like mutations, which confers very high probability of intermediate risk cancer. Again, choice of surgery lobe versus total thyroidectomy should be dictated by clinical parameters. And finally, 2 to 4% of all indeterminate thyroid cytology nodules will come as positive for high-risk mutation. This is the most valuable and most important test result, because these patients have extremely high probability of high-risk cancer. These patients need total thyroidectomy. Probably most of them will need radioactive iodine, because these tumors will comprise the largest pool of tumors that eventually recur and lead to patient death. So this is how, using modern molecular testing, you will get additional information that can help you to individualize the management of patients with thyroid nodules with indeterminate cytology. With this, I want to thank for your attention. I will be happy to answer any questions that you have, and I want to leave you with my email address here on the screen. So if I cannot answer any of your questions, please feel free to send me an email, and I will be glad to provide information and share information that I have on this topic. Thank you very much for your attention.
Thank you, Professor Yuri, for this very informative, comprehensive presentation, and we'll leave the questions and answers till the end with the 3 speakers.